Now let's discuss the next set of Harrison charts. Coming to risk modifications to reduce perioperative pulmonary complications. Preoperatively, cessation of smoking for at least 8 weeks before and until 10 days after surgery, training in proper lung expansion techniques, inhalational bronchodilator or steroid therapy, control of infection and secretion when indicated, weight reduction when appropriate. Intraoperatively, limited duration of anesthesia, avoid of long-acting neuromuscular blocking drugs, and prevention of aspiration and maintenance of optimal bronchodilation. Post-operatively, optimization of inspiratory capacity maneuvers with attention to mobilization of secretion, early ambulation, encouragement of cupping, selective use of nasogastric tube, and adequate pain control without excessive narcotics. Indications for cytogenetic and cytogenomic analysis across the lifespan. And prenatal testing is done for advanced maternal age, abnormalities on ultrasound, increased risk for genetic disorder on maternal serum screen. Neonatal and childhood, when the child has multiple congenital anomalies, intellectual disability, autism, developmental delay, failure to thrive, short stature, disorders of sexual development, history of familial chromosomal alteration, and cancer. In adult, it is done in case of infertility, recurrent miscarriage, and familial cancer. Severity of physiologic stimulation and depression, poisoning and drug withdrawal. Physiologic stimulation is grade 1, is anxious, irritable, tremulous, vital signs normal, diaphoresis, flushing, pallor, mydriasis and hyperreflexia sometimes present. Grade 2, the patient is agitated, may have confusion or hallucination, but can converse and follow commands. Vital signs are mildly to moderately increased. Grade 3, the patient is delirious, unintelligible speech, uncontrollable motor hyperactivity, moderately to markedly increased vital signs and tachyarrhythmia is possible. Grade 4 is grade coma, seizures and cardiovascular collapse. Physiologic depression is grade 1. The patient is awake, lethargic, sleeping but arousable by voice or tactile stimulation, able to converse and follow commands, may be confused. Grade 2 is response to pain but not voice, can vocalize but not converse, spontaneous motor activity present, brainstem reflexes intact. Grade 3, unresponsive to pain, spontaneous motor activity is absent, brainstem reflexes are depressed, motor tone, respiration and temperature decreased. Grade 4 is unresponsive to pain, flaccid paralysis, brainstem reflexes and respiration is absent. Cardiovascular vital signs are decreased. So these are the grades of physiologic stimulation and physiologic depression in case of poisoning or any kind of drug withdrawal. So fundamentals of poisoning management is supportive care, that is airway protection, oxygenation, ventilation, treatment of arrhythmias and hemodynamic support. There is treatment of seizures, correction of temperature abnormalities, correction of metabolic derangement, and prevention of secondary complications. Preventions of further poison absorption when there is gastrointestinal decontamination by gastric lavage, activated charcoal, pore bowel irrigation, dilution, and endoscopic surgical removal. Decontamination of other sites, one is eye decontamination, skin decontamination and body cavity evacuation. Enhancement of poison elimination, that is multiple dose activated charcoal administration, alteration of urinary pH and chelation. Extracorporeal removal, it can be hemodialysis, hemoperfusion, hemofiltration, plasmapheresis, exchange transfusion and hyperbaric oxygenation. Administration of antidotes, that is neutralization by antibodies, neutralization by chemical binding, metabolic antagonism and physiologic antagonism. Physiologic antagonism is when they act on two different receptors, but their actions are exactly opposite to each other. Prevention of re-exposure, it is adult education, child-proofing, notification of regulatory agencies and psychiatric referral. Risk factors for hypothermia, age extremes like elderly and the neonates, environmental exposure, that is occupational, sports related, inadequate clothing and immersion, Toxicologic and pharmacologic like ethanol, phenothiazine, barbiturate, anesthetics, neuromuscular blockers and antidepressant, insufficient fuel that is malnutrition, marasmus and kwashiorkor, endocrine related that is diabetes mellitus, hypoglycemia, hypothyroidism, adrenal insufficiency and hypopituitarism. Neurological it is CVA, hypothalamic disorders, Parkinson disease and spinal cord injury. Multisystemic, it is trauma, sepsis, shock, hepatic or renal failure, carcinomatosis, burns and exfoliative dermatologic disorders, immobility and debilitation. Use of anticholinesterase inhibitors in innovations by neurotoxic snakes and coon snails. On these patients with clear objective evidence of neurotoxicity, there is ptosis, inability to maintain upward gaze, should receive a test dose of edrophonium if available on histamine. Pre-treat with atropine that is 0.6 mg IV. Treat with edrophonium 10 mg and neostigmine 0.02 mg per kg IV or IM. If objective improvement is evident after 13 minutes, treat with neostigmine that is 0.5 mg IV, IM or subcutaneous every hour as needed. Atropine 0.6 mg as IV continuous infusion over 8 hours. Closely monitor the airway and perform endotracheal intubation as needed. Remove from the environment, prevent partial thawing and freezing, stabilize core temperature and treat hypothermia, prevent frozen part, protect frozen part, no friction or massage, address medical or surgical conditions. Consider parenteral analgesics and ketorolac, administer ibuprofen 400 mg, immerse part in 37 to 40 degrees Celsius. Which is thermometer monitored circulating water containing an antiseptic soap until distal flush. Encourage patient to gently move part. If patient is refractory, reduce water temperature to 35 to 37 and administer parenteral narcotics. After thawing, that is generally dry and protect part, elevate and place pledgets between toes if macerated. If clear vesicles are intact, aspirate sterilely. If broken, debride and dress with antibiotic and sterile ointment. Leave hemorrhagic vesicles intact to prevent desiccation and infection. Continue ibuprofen. Consider tetanus, streptococcal prophylaxis, elevate the part. Administer hydrotherapy. Consider dextran, phenoxybenzamine or severe cases thrombolysis. IV or intraarterial. So this is a treatment for frostbite. Management of altitude illness, acute mountain sickness that is mild, discontinuation of acid, treat with acetazolamide 250 mg Peltali and descent. Moderate, immediate descent for worsening symptoms, use low flow oxygen if available, treatment with acetazolamide and dexamethasone 4 mg 6 tali, hyperbaric therapy. High altitude cerebral edema, immediate descent or evacuation, administer of oxygen 2 to 4 liters per minute, treatment with dexamethasone 8 mg per oral, then 4 mg 6 tali, hyperbaric therapy if descent is not possible. High altitude pulmonary edema, immediate descent or evacuation, minimalization of exertion when patient is kept warm, administration of oxygen that is 4 to 6 liters per minute to bring O2 saturation to greater than 90%, adjunctive therapy with nifedipine 30 mg extended release, hyperbaric therapy if descent is not possible. So options for extracorporeal blood rewarming. One is continuous veno-venous rewarming. Circuit is CV catheter to CV, dual lumen CV or peripheral catheter. No oxygenator or circulatory support. Flow rates is 150 to 400 ml per minute. Hemodialysis. Circuit is single or dual vessel cannulation, stabilizes electrolyte and toxicologic abnormalities. Exchange volumes are around 200 to 500 liters per minute. Continuous arteriovenous rewarming, percutaneous femoral catheters require systolic blood pressure monitoring of pressure of 60 mmHg. No perfusionist pump or anticoagulation. Cardiopulmonary bypass and extracorporeal membrane oxygenation. It is full circulatory support with pump and oxygenator. Temperature gradient is 5 to 10 degrees Celsius. Flow rates are 2 to 7 ml per minute. Extracorporeal membranous oxygen ECMO, that is ECMO, there is decreased risk of post-rewarming cardiorespiratory failure.